Good evening. I'm Dr. Pankaj Gupta. Today I will be talking to you about clinical decision support CPOE BCMA standards. And this is going to be a lecture on all the details about CPOE and BCMA. Um, Full form of CPOE BCMA, computerized physician order entry, and BCMA stands for barcode medication administration. These are two standards which were established in the US long time back. They are built into electronic health record systems, electronic medical record systems. There's been a few implementations of those systems in India. I'll talk a little bit about it. But today we are going to jump into the nuts and bolts of what we basically mean by the concepts of CPOE BCMA. So today is going to be a little more nuts and bolts, a little more deeper dive of the concepts that we have learned. And this is something that we are trying to sort of
Dr.
go deeper.
Pankaj,
Yeah.
sorry to interrupt you. Seems like from your PC you have logged into Meet as well as StreamYard, and both the mics are on.
Okay. I have not logged into Meet. I have not logged into Meet. I am only on StreamYard.
Okay, let me check on. Yeah, just give me a minute. Let me check with the participants on the Meet if there is a double voice coming, because that's what I was hearing.
Yeah, please.
Dr. Pankaj, we can try again.
Okay. Um, okay. Let us try to do full screen mode and try again. If my screen is visible, the agenda for today is healthcare IT evolution. We will be looking at Institute of Medicine report. That was a report released in the US about CPOE. The Leapfrog group, that is an organization that was created for basically looking after the standard of CPOE's implementation. And then we'll go into some examples of CPOE. We'll also look at an evaluation application, some of the case studies, and then we get into challenges and questions. So that's pretty much the agenda for all the presentation that I have today. Let's start with the first one, which is basically the healthcare IT evolution. How has this evolution happened? So the evolution, so it started with simple stuff in terms of data capture systems. Now, if you look at data capture systems, most of your public health systems in India, which are program based IT systems, these are data capture systems. These are one dimension data capture. So the data is captured from the district and sent to the directorate. And then they really don't do anything much. So these are collector systems, very basic systems that were developed in the past, and they continue to exist. The next level is systems which are basically uh, department workflow automation systems. So department workflow automation comes when the file, so there's a proposal created on a file, the file has to move, different people act on the file, and there is some action or decision that has to be taken. So those are department workflow automation systems. So you will see some of those automation systems in the public health, but not too many of those out there. Some you will see some of that in the ministries and departments at the state government level, but not really a whole lot. The next level is enterprise integration, where you have different systems like the CRM, supply chain management, hospital information system, lab information system, pharmacy information system. They're all being integrated into an integrated enterprise, and that is something which happens most often in India and in the private sector. So large hospitals and chain of hospitals are still at this level where they are struggling to integrate different systems, and this is called enterprise integration. Um, Really, things haven't moved beyond this in the last so many years that I have been watching. The entire healthcare IT industry seems to be struggling with this in India, but in many other parts of the world, things have moved forward into personalization. So consumer relationship management. So it has become very personalized. So the system behaves as if the system knows the doctor, and the system also knows the patient. So that's a very personalized way of handling. So there are web-based portals, there is disease prevention that gets built into it, and things like that. So you will see. I can give you an example, which is a non-healthcare example. For example, Netflix. Netflix knows your behavior, your viewing behavior. It knows at what point in time or at what time of the day you are watching what kind of movies and documentaries and things like that, and at what time of the night you are binge watching, and you are watching some movies and films and things like that, which are of your choice. So it sort of understands what kind of choice you have at what point in time and all that. So that is personalization of, and what it does is it gives you alerts, it gives you reminders, it gives you suggestions. So the system becomes personalized. The next level is evidence-based medicine. So in evidence-based medicine, CPOE comes at the top. Now CPOE is uh, basically that all the data is required to make CPOE decisions happen. So CPOE is where the system is like looking over the shoulder of the doctor, and then it is sort of telling the doctor that maybe these are the few more things you may want to look at. So it is almost like looking over the shoulder of the doctor and making suggestions as a mentor, as a friend, or you can say somebody who knows a lot of data, which is hard for any human to keep in his or her head. So this is right at the top of the hierarchy, and these systems haven't really been adopted big time in India, but outside India they have been a lot. In India there are a few examples of it, like Max Healthcare. We did that implementation We, as in, me, my team, I created a very specialized team to do it way back in 2009, and this went on till 2012. And it was a system that was well recognized from the HIMSS at a stage 6 level. So that's one example, but there are not too many of those examples out there in India. So it takes a lot of knowledge and an integrated system environment to be able to achieve a CPOE implementation. So this is the HIMSS Analytics IMRAM that I was talking about. So Max Healthcare was accredited at stage 6, which is basically technology-enabled medication. So it's CPOE plus BCMA. BCMA is a technology-enabled medication. We'll talk a little bit more about it as to what that means. But CPOE is where you give the orders, and the system is intelligent enough to figure out whether the order is a right order, or there needs to be an alternative thinking. So there is a clinical decision support system which is looking over the shoulder of the doctor and constantly helping the doctor in terms of making the right decision. That's CPOE. And BCMA, barcode medication administration, is a mechanism where the system is helping make sure that the drug which was ordered is the drug which is administered. To make sure that the same drug is administered, whichever was ordered, there are a whole lot of technology interventions that are done, and we'll see some of those with examples as to how to make that happen. So there are only about 40 hospitals globally that are at stage 6 accreditation. So you can imagine stage 7 is even lesser. And one of those hospitals is in India, which is Max Healthcare group of hospitals. Yeah. So this is a very coveted status to have, because it requires a completely integrated model, all the systems sort of integrated together, and with a lot of intelligence built into the system to be able to have a CPOE BCMA implementation with full clinical decision support. Um, in the US, when the meaningful use was implemented, this is when Obamacare, you might have heard the term Obamacare, and over there for CPOE, medication, laboratory, and radiology orders, they said that about 60% or more than 60% of medication orders should be through a CPOE enabled system, and 30% of laboratory orders should be through. So these are targets given, that if you are able to achieve these targets, then the incentives, the tax incentives that were given by Obamacare, they become applicable. So CPOE was tightly bundled into the meaningful use model, and it was delivered together with that. Similarly, electronic medical administration record, which is also called IMRAM. So for IMRAM, there were standards built into the, EMAR standards were built into the entire meaningful use, where they said, at least 10% of the medication orders should go through EMAR, which is electronic medication administration record. And these standards are not very high. I mean, the target is not very high, but they wanted the market to adopt it. So this was sort of built into the meaningful use. So you can see the cycle. So there is an orders. This is where the clinical orders are given. A lot of research has said that about 56% of the errors happen at the order stage, and then after the orders, the drug is dispensed at the pharmacy, and then from pharmacy it comes to the nursing station, and then it is administered to the patient. So there are about 6 rights which the CPOE basically sort of makes sure that the 6 rights happen. What are those 6 rights? So it should be the right patient, the right medication, the right dose, the right route of administration, the right time, the right reason, and the right documentation. So CPOE makes sure that all these rights are in place. And with BCMA, you're able to sort of technologically determine that whatever the medicine that was ordered is the medicine that actually went into the patient. How do you make that happen? So here is CPOE orders. To give CPOE orders, you have tablets. And in most of the hospitals, what is advised is tablets which can be sterilized, which can be sanitized. And, these are hard tablets. If they drop, they don't break. So, many of these models you will see in hospitals that are available. So they are given to the physician, they are given to the clinician, they are given to the nurses, so that the orders can be given at the bedside or anywhere, wherever, on the move, when the doctors and the nurses are on ward rounds, they can give the orders. This is connected to the electronic medical record of the patient, which you can see here. The chart is there. And as soon as the order is given, the order is sent to the pharmacy electronically. Because it is an integrated system, we are assuming that it is an integrated system, the order is directly sent to the pharmacy. So this is the CPOE order stage. Now we'll look a little bit more into what CPOE does, but just sort of at this stage, what happens is it's an intelligent system. So it's a CPOE system with a lot of database built into it. So it has a lot of knowledge base built into it. So this knowledge base is looking over the shoulder of the doctor, and it is telling that if there is an allergy, it may alert the doctor, here is an allergy, and you may want to sort of change the medicine. If there is a duplicate order, it will say that the order is duplicate, and do you want to look into it? Or many such examples. So there are 14 different categories of alerts that the CPOE throws at the clinician, and makes sure that there is no error at the order stage itself, because once it crosses this stage and the error is there in the order, then the system sort of will take whatever the order as a gospel. So CPOE makes sure that there is no errors in the order, or reduce the chances of errors in the orders. So the next stage is at the pharmacy. The order has already arrived in the pharmacy system. Now the pharmacist prints a barcode and labels the sachet or the packet or the tray on which the drug is being sort of put, and then scans that barcode so that the unique number of the barcode is connected to the order that came from the physician and to the patient. So at this stage, the pharmacist is making sure that he or she is dispensing the medicine whatever was ordered by the physician, and the system knows it, that it is the same drug, whatever was ordered is being dispensed. And then it is loaded into this automatic cart, and this automatic cart can be a robotic cart. It can move around the hospital automatically, or it can be pushed around by a GDA, so that the cart can be taken to every nursing station, and then at the relevant nursing station, the cart having the labeling and everything, and the numbering system is there in the cart where it tells you that so and so nursing station, so and so tray needs to be taken out and kept for that nursing station. So all that labeling system is there, and it sort of is pretty much a no-brainer. So both the options are available. In India, I have not seen a robotic automatic cart. I've seen it in many other parts of the world, but in India, it's mostly computer on wheels with a cart, which has these trays loaded on it and a GDA pushing it around from nursing station to nursing station. There is another option, and that is a pneumatic chute. So I've seen in some hospitals they have a pneumatic chute. So the pharmacist loads the medicine into a pneumatic chute, and the pneumatic chute takes it to the relevant nursing station depending upon the label that was there on in the medicine that was loaded into the chute, and the nurse here is taking it out. Once it is taken out either from the cart or from the pneumatic chute, then the nurse will scan the medicine that was given to her, and then the system will check whether it is the same medicine which was dispensed, whether it is the same medicine that was ordered. So the system will make all that checks, and then it will give you a green light or a beep saying good to go, and this is the same. So basically the nurse is confirming that I have received the medicine which was ordered. It is the same medicine that was ordered, and it is the same medicine that was dispensed. So it's a confirmation. Next stage is medicine administration, when the nurse goes to the patient and scans the barcode on the patient's wrist and makes sure that that information is captured, and then scans the drug itself, either a QR code or a barcode that was labeled or put onto the drug that was dispensed. So that is sort of done, and then the system matches all of this information and says this is the patient for which the order was given, this is the patient for which the drug was dispensed, and this is the same drug that was dispensed and ordered. So once all those confirmations are done by the system gives a beep and says yes, you can administer. And that is when the nurse will take out the medicine, load it into a syringe, or whatever the route of administration, will do the administration. By doing this entire cycle, the system makes sure that the errors that could have happened either at the ordering stage or at the dispensing stage or at the administration stage or anywhere in between are eliminated. Now, this can happen only if uh, the systems are integrated. Imagine if the systems are not integrated. So there is a patient allergy, physician orders an alternative medication, the pharmacist dispenses the previous medication because the pharmacist doesn't know that the physician has changed the medication. Nurse administers the medication whatever was given by the pharmacist and doesn't know that the physician changed the medicine, or doesn't sort of get any alert unless she sort of is keeping record and very alert, and there's a change she needs to sort of, so she just believes that the pharmacist may have sent the medicine whatever as the change medicine, and the wrong medicine gets injected or administered. So obviously there are consequences of that. The patient may have serious side effects, serious effects, leading to longer hospitalization, and so many other things can go wrong. The executive lacks solid data to figure out what went wrong. So all those things can happen. These are preventable errors. So additional days in the hospital, additional costs, possible lawsuits. So lots of things can go wrong in situations like this. So if there are disparate systems, then this is what happens, what I narrated. However, if it is an integrated enterprise, then the system will give an alert that there is an allergy or there is a reason for which the medicine needs to be changed. physician makes a change in the drug or in the order, it is communicated to the pharmacist. The pharmacist gets notified of the change, dispenses the correct medication. It's pharmacist will not dispense on the previous medication or the previous order. The previous order is automatically stopped in the system. In a paper-based system, this is not possible. So what happens is this can be done only in an integrated system where different parts of the system are integrated together. So there is a hospital information system, there is a pharmacy system, there is a nursing workbench, there is an ordering system, there is a reporting system. All of them have to be integrated together either by design or by using standard interfaces. Some of the standard interfaces as we have defined, and you learn in subsequent lectures. If those standardization is done, only then you can achieve integrated enterprise and you can have a good outcome. Otherwise, there are very good chances that cpoe bcma will completely fail if the systems are not integrated. um, Institute of Medicine study happened in the US. So Institute of Medicine released a report called To Err as Human. And this report was a landmark in the US. What it said was about 98,000 people die in the US every year because of preventable medical errors. Now, this number is higher than the number of people that die because of motor vehicle accidents, breast cancer, and AIDS. So all of that put together, is equivalent to or lesser than this, the preventable medical errors that happen. So what happened is this report shook up a lot of large employers. So you had large employers that employ large populations in a particular region. I can give you some examples. If you were to go to Michigan, then that's a place where you have large employers which sort of run the pretty much the economy of that place. So these are all automobile manufacturers. So Ford runs or employs a very large population in Michigan. If you were to go to Seattle, it is said that either you are working for Microsoft or you're working for Boeing, or you are related to somebody who is working for either of these two. So that is the kind of large enterprise or large companies that exist over there. And many of these large corporations, they got together and they said, we need to be responsible for the safety of our employees, because if they are safe, then they can be productive. And how do we keep them safe? If so many preventable medical errors are happening, then how do we make sure that they remain safe? And that is when the Leapfrog group was created. All of these large enterprises came together and created the Leapfrog group, and they put patient safety standards in place. The Leapfrog group was a consortium of about 500 companies, and these are Fortune 500 companies, um, supported by large private and public purchasers. And these healthcare purchases had to be based on principles that encourage stringent patient safety measures. So basically, the Leapfrog group said that all the healthcare purchases that happen will be based on some standard principles. So that is those are the principles of the Leapfrog group on which this was created. The first principle was computer physician order entry, in which they said, uh, all the the order entry is going to be based on standards, which is CPOE orders, and there needs to be an attempt to capture other erroneous orders also. Then the second thing that they said was that sick people need special care, and ICU daytime staffing with the CCM trained medical doctor should be there. So that was the second thing that they said. And the third thing they said was any referral, any hospital based referral needs to be evidence based, and this evidence base needs to be based on EHRs. So it was a path breaking change that came from the Leapfrog group, and they set in a whole lot of these standards to be followed for patient safety. In this lecture, we're going to focus only on the first one, which is computerized physician order entry, and related, which is BCMA, or the barcode medication administration. Why CPOE? It is obvious. The left hand side, know that's how lots of paper is in our hospital even today. And right side is again obvious. If you have an electronic system which is properly structured, then you won't have the chances of errors that you can see on the left hand side, the written orders that you have in your paper. The right hand side are your clinical orders, which are very well structured in an electronic system with all the knowledge base CPOE built into it. So here are some of the further rules of CPOE. You can read it. It is there in the slide deck, and I may not sort of go into all the details, but it's available to you. You can read up more about the Leapfrog group. I'll go into some of the examples of CPOE. Here is an example of drug duplication. So you can see there are two orders or three active orders of hydromorphone. And this is something which should not have been done for sure. So the system gives an alert and says, why are three orders of hydromorphone? Um, it gives an alert to the physician and says, are you sure that all the orders are accurate, or would you want to delete two or all the three orders and give a fresh order? So that is an alert that the system will throw at the doctor. Of course, clinical judgment is supreme. The doctor can decide, and the doctor can say that, no, I need all the three orders, and the system will say, all right, please go ahead. Similarly, an allergy. So if there is an allergy recorded in the system for hydromorphone, and still the order is given, then it will throw an alert to the doctor and say, hey, there is an allergy. So are you still sort of going to order hydromorphone? So in all likelihood, the doctor will withdraw that order and say, yes, let's give another different drug to the patient. Here is a drug-drug interaction. So, if you were to give any of the narcotics together with atenolol, there is a good chance that there will be a central nervous system depression, and this is something that has to be avoided. So the system has enough intelligence built into it to throw an alert at the doctor and say, hey, do you want to give any narcotic with atenolol? I think you should be avoiding it. So the doctor will most probably make corrections. Here is another example of drug-food interaction. So if a patient is on warfarin, and the food items that are being given to the patient are very rich in calcium and vitamin K. So if they are very rich in vitamin K, then what will happen is the system will calculate the food value and say that a lot of vitamin K is being pumped into the system of this person. So obviously the effect of warfarin is going to come down. So it's an antagonist. And are you really sure that you want to do this? So this is a drug food interaction example. and the food which is being given to the patient, the total value of the calorific value, and also the value of various nutrients which is being given, is calculated by the system, and alerts could be thrown based on that. So here are 14 different categories. So basic, advanced, and expert level. So I'll just read out the categories, and the rest of it is something which is already there. You can read it up. So therapeutic duplication, we already saw an example. Allergies and cross allergies, we saw an example. Contraindicated route of administration. So that is if something that was to be given by an injection route, but the order said give it orally. So contraindicated route. Drug and drug food interaction, we just saw an example of both of them. Contraindicated dose limits. So there is a contraindicated limit. So you can't really go beyond a certain dose, but it has been done. Then dose limits, contraindicated dose limit based on age, based on gender, based on so many other factors, the clinical conditions. So the laboratory values, so drug lab interactions, and then those limits based on radiology studies, so and so. So all these different examples of alerts are there, and cpoe systems are intelligent enough to figure out all of this and throw an alert at the doctor and say, hey, maybe these are the things that you need to consider before you go ahead and give this order. Here is a evaluation system that I helped develop long back when I was working with FCG, and this still exists. The system still exists. It is in use for evaluation of various hospitals, whether they are compliant to the cpoe standards or not. So, as I said, clinician judgment is supreme. If the clinician decides to override and ignore the alerts, that's perfectly fine. That is allowed. Somebody can say bad practices, but yeah, fair enough. The clinician judgment is supreme. So if the system is throwing alerts, so just throwing alerts is not enough. You need to ask what makes the rules fire, because alerts are based on some rules which are written underneath. So are those rules clinically relevant? Are there clinicians who have written those rules? So all the orders, notes, lab results, so it's based on a clinical protocol. So is it based on clinicians being involved in writing those rules? The second thing is, when does the rule fire? So again, is it firing when a certain action is taken, or the rules are just firing off without any action being taken? Again, a lot of clinical knowledge needs to be built into software development. How does the rule get into the use? How? So you need to ask all these questions: what, when, how. When the escalation happens, is there enough intelligence or forward chaining of the rules? So if there is a rule that is switched off, so will there be a next level rule that will fire? So those sort of things are something that you need to ask. So these are intelligent questions that you need to ask, because not every system will have all these rules built into it now. But unless these rules are built into it, it's not really a clinical decision support system, and it's definitely not a cpoe system. So you need to ask more questions. And then if the rules are being sort of given with a delay, that really doesn't help. So and then if too many alerts are coming, the doctor and the clinicians are going to get upset, and they're going to say too many alerts. So it should not be information overload, and it should not be delayed messages. because in either case, the clinicians are going to get upset. Here are some case studies. So here is a case study from University of Virginia, where the cpoe implementation had to be switched off, and it was switched off because of a human issue. It was not really a technology issue but a human issue, and it was forced people to modify their established routines, so challenge the basic institutional assumptions. Now that always happens. So see, when you are implementing cpoe and bcma, your processes are going to change, and when the processes are going to change, people are going to feel uneasy, and when they are going to feel uneasy, you will have to support them to get adjusted to the new routine, to the new way of doing things. If they are not supported, then they are going to get overwhelmed, and they will result in the failure of the implementation. When we did the largest implementation that I talk about in India, many of these things happened. A lot of physicians, a lot of clinicians, a lot of nurses came up to us and said, "You're changing the way we are working, and this is not acceptable to us." Many of them, even said, "We are going to resign," and some of them did resign. But the decision of the board was firm that we have to make this change. We will make this change, no matter whatever the cost. And so whoever resigned and went away, but the organization went ahead with the implementation. And fair enough, some of them went away, but many of them reconsidered their resignation and came back. So all those things do happen. So human element becomes a difficult one to handle, especially when clinicians get upset. There is a risk of derailing the implementation of cpoe. Here is another case study, Cedar Sinai. An application had to be turned off even though it was working. So the physician said that too much unnecessary decision support. So it is giving me too many alerts. It is telling me what to do, what not to do, and I don't like it. So they had to switch off the system. The best examples or best success stories have come from Dr. David Bates, who actually did a lot of implementations, and he figured out that about 55% reduction in error rates can happen if the implementation is done well. And many of the other case studies are also here, so you can look it up. When you Google it, you can find very detailed papers for each one of these case studies, just given references here. Coming to challenges, so incentives. So incentives paid for implementation, not the product. So if you do a successful implementation, then the incentives can be paid, but not just for buying the product and keeping it like a showpiece, right? So that doesn't help. Different systems. So outpatient order systems, inpatient order systems are different systems. Like you do see that in most of the hospitals in India, that OPD system is different, inpatient system is different. And that is a huge challenge, because then you really will not be able to bring all the orders together. If you can't bring the orders together, then you will not be able to have a decision support system that is intelligent enough to be able to tell you. So if there is a duplicate order, so there was an order given in outpatient, there was an order given in inpatient, and these are duplicate orders. The system doesn't know it, because these are different systems, and it will not be able to throw an alert. Group of hospitals. So when there are a group of hospitals and each hospital has a different HIS system, again, the databases are not common, the EMRs are not common, so enough intelligence is not available, or enough data is not available for the clinical decision support system to be able to throw errors, or to be able to point out that here are duplicate orders, or here are allergies, because these are EMRs are different EMRs, even though the hospital may be co-located, but different EMRs. Like for example, many times you have different institutes within the same hospital, and each institute has their own EMR system, and they are not integrated with each other. So those kind of challenges will happen, and the clinical decision support system will not work. Direct orders. So many times orders are given directly to the lab, or orders are given directly to the radiology, and they're executed there itself. Now that the report may come back into the system, but the order is not there. So so the system doesn't know whether there were duplicate orders or not, or unnecessary orders were given or not. So the system will not know if the orders are direct orders. Additional orders are given directly to the lab, and then it's not in the system. The denominator can be elusive because the orders are outside the system. So the total number of orders given, so if you have to calculate the ratio, you cannot calculate the ratio because the denominator is elusive. So the confidence level versus return on investment, so that is another challenge as to how do you figure out what is the confidence level and what is the real return on investment. Some more challenges: integration issues. As I mentioned, data is in silos. Data loss happens in integrating or interfacing different systems which are not really built for interfacing, and data loss may happen because of that. Hardware issues: Wi-Fi scanner issues, scanner not working, Wi-Fi not working, new nurse not yet trained, so human resource issues. Retrospective catch up after emergency. So in emergency, nobody wants to sort of focus on the documentation. So you catch up on the documentation retrospectively. And in the meantime, when you do the retrospective catch up, the system is going to start throwing, lots of alerts that, these orders were given, back in time, and you're making the entry now. So even those alerts will start firing. So those kind of things will happen. So you'll have to switch off the alerts anyways. Then patient ID band has been cut off. So because of whatever reason, the ID band has been cut off. So you really don't know it is the same patient or a different patient. Miscoded medications. So the code that was actually barcode that was printed and put on the vial is miscoded. Empty units. So single dose packages that were sent, those are empty. So if it is empty, even though the system says received, scanned, but at the time of administration, the packet is empty. So these are real big challenges that can happen. These are all human errors. These are all errors that the system will not be able to catch. Delivered without scanning. So there can be people who just pick it up. So at the time of dispensing, the pharmacist dispenses it but forgets to scan. At the time of receiving it, the nurse receives it but forgets to scan. At the time of administration is done but forgets to scan. So the system doesn't know whether the administration really happened or not. Damaged barcodes which are not readable, they get smudged or whatever. So barcodes are not readable. Override alerts. So alerts are coming, system is saying, hey, things are going wrong, and the clinicians are just overriding the alerts. Sometimes they switch off all the alerts because they really don't want to be disturbed, and that's a challenge, right? So all these challenges, I can just go on and on the challenges list, but I will stop at that, and maybe we can take some questions. Thank you so much for listening to me.